Do you know for you to have one ICU bed in a hospital, you need 5 nurses. So you don't have cash flow, you don't have a business.
Yeah.
And this is something you're not taught in medical school.
Thank you, Dr. Msafiri, for coming to the program.
Yeah.
Actually, it's not a program; it is a conversation
Yeah.
at the entrepreneurship drive. So we are happy to have you today,
Yeah.
Dr. Jeremy Gitau, so that we can be able to enlighten us on this business of Dr. Msafiri, so that we are able to, and also a little bit about wellness. I think it will be handy, so that our viewers can be able to benefit from your wealth of knowledge.
Yeah.
So I think we'll begin with the introduction. I would ask you to introduce yourself in the best way possible.
Okay. Yeah, so yeah, I'm Dr. Jeremy Gitau. I'm an emergency physician by training, but I practice more of what is called home-based care, with more training on geriatric and palliative care. So my focus is mostly on now geriatric is the elderly. Those are the majority of the clients we attend to. But I still have my heart as an that's my background, emergency medicine. I've been a doctor since 2008, so more than 15 years experience.
Yes.
Having trained at University of Nairobi. I've also trained at Aga Khan and also University of Cape Town and the UK. So to attain now my training as a flying doctor.
Okay.
Yes.
Flying doctor.
Yes.
So as a flying doctor, you fly the aeroplane with the tools of medicine. Or how would you define a flying doctor?
There is a friend of mine once told me, umekuwa makanga wa ndege.
Yes.
And basically what happens is you're more like a flight attendant, because you fly, you're the one escorting now the patient, but in the flight. So we don't fly it, but we are with the patient as a doctor. So you're actually working. You're taking care of that person. Most of the time utapata, we get them from a hospital.
Yes, yes.
And you're taking them to another hospital. So they usually what are called inter-hospital transfer. So for example, a hospital here in Kenya and another hospital in London, for example.
Okay, okay.
So you're the doctor who takes the patient, take them from the hospital with a ground ambulance. Then you go and load them in an aircraft. Then from the aircraft, they go to their country of destination.
Okay, okay.
So you make sure that you're maintaining the same care as they were receiving in the hospital. Yeah.
Oh, so why is it important, expound a little bit on that, why is it important to have a patient flown to another hospital with a doctor?
So one is you find their patients, mostly the patient is unstable. So they're still requiring care, because the reason you find most patients, one of the reasons they go to another country, for example,
Yes.
is either to seek a second opinion, or if they require a specialized treatment that is not
Yes.
locally available.
Yeah.
And interestingly, we also bring in a lot of patients to Kenya, for example. So from other countries. So you'll
Like
fly
this is London.
for other people.
They said this is half London at some point. This was a half London for East Africa.
No, actually, interestingly, when you look at the medical tourism right now, in
Yes.
general in the world, for Africa, Kenya has become a hub.
Wow, that's interesting.
Yeah, so you find a lot of people flying from, like recently, about 2 weeks ago, we flew our client from here to Addis, and they had actually come in. They had been flown in from Addis to Kenya, and then we flew them back to.
That means we are very advanced in our medicine here.
Yeah, Kenya is quite advanced. If you compare Kenya to other, even in the East Africa, Kenya is a medical hub, and that creates many opportunities even for like tourism, for example.
Yes.
We have even the public hospitals, for example. Like this particular client was actually at the Kenyatta University teaching a referral hospital,
Yeah.
where they had come for specialized cancer treatment. So you find before, many people were going to India and now are preferring to come to Nairobi for treatment. And mainly because we have, like, for example, we have the PET scan now that has been installed at KU,
Yeah.
the referral hospital. So you find the same services you'd find in India, they are also locally available.
They're locally available.
So we have a lot of people, and then also the private hospitals have also advanced. We have, in fact, the care you receive in Nairobi, the same care you'd receive anywhere in the world.
Wow, that's interesting. So it's a
Yeah.
matter of just perception.
It's a matter of perception, it's a matter of also cost.
But it depends, Daktari, because if you're in Nairobi hospital and if you're in a public hospital, maybe not.
Yeah, that's why I said it's a matter of cost
Yes.
and preference.
Yeah, I hear you.
So if you go to a private hospital, it may be more expensive for you,
Yeah.
especially if either you don't have the cash or if your insurance is not able to take you there.
That's right.
But the same care that is in those private hospitals, the same care you find in London, you find most people have actually been trained
Yes.
in the same facilities. The people working in London, we have doctors who are working here who've actually trained in the same facilities. And you're able to receive the same care as you'd get when you're...
Yes.
So that's why I say it's a matter of preference. So you find some people will say, I want to be flown to South Africa. Just as a matter of preference. But it's not that South Africa has better care than Kenya.
Than Kenya.
Yeah, what may be different is the attitude of the people, because you find different cultures have different attitudes. You find a lot of people prefer going to India because they are very warm, they are receptive. They already have figured out the tourism, and for them they take it very serious. So you land there, you go to, so rarely will you hear somebody saying they went and got care that is different from what they were getting here. But what actually they got is the hospitality.
The hospitality.
Actually, it's more of the hospitality industry
Yes,
that
yes.
is better
Yes.
than the medical care that is here.
Oh, okay.
Yeah. So that's what people prefer. And of course, sometimes the cost in India may be lower as compared to the one here. But in terms of medical care, we have the same care that you'd get in any facility in the world.
By the way, what is the driver of this cost that makes it, because the medicine is still the same, what are
Yes.
the differences that would make medicine in India a little bit lower than in Nairobi here?
So they manufacture, there's a lot of manufacturing happening in India, for example. So in terms of, so manufacturing is cheaper there. Maybe their labor costs are also cheaper. So them they're able to give healthcare at a lower cost than the one we give here.
Yeah.
But in terms of equipment, it's the same MRI machine. We have the latest MRI machines in the country as we would have there. So there's no difference in terms of equipment, in terms of skills. What is different is the cost of labor and maybe costs related to medication that they're manufacturing locally. Yeah.
So right now, your background is more for, you said, emergency medicine,
Yes.
flying doctor,
Yes.
but now you ended up with, is it the same as home-based care or is it different, so that now you came to Dr. Msafiri is more related to flying doctor?
So what happened is, so I used to work as a flying doctor for some time. And people, my friends actually, would, you know, the way they call you and there's that ringtone when somebody has traveled.
Yes.
So they will know I'm out of the car just because of the ringtone.
Yes.
And they will start saying, hey, wewe umekuwa msafiri sana. Wewe ni kama umekuwa Daktari Msafiri. So that was a nickname.
Yes.
So nickname, people started calling me Daktari Msafiri. Then hey, Daktari Msafiri, umesafiri wapi sahi? You know, like that. That's how it started.
Yes.
Then one day, I'd actually traveled. I was with another client. I'd taken them to the US.
Yes.
Then a friend calls me and tells me, there's a patient who is in one of the hospitals here in Nairobi and they would like to go to South Africa for treatment. Are you available? So for me, I thought, yeah, I can be available at which dates. For me, I switched dates, and my question was, do I have to spend the night? If not, then I'll come. So immediately I got back, we organized, we took the patient to South Africa. They stayed there for a month. After 1 month, they called me and they were like, hey, Daktari, we were happy with your services. Can you come and take us back to Nairobi? So I went and took the mom.
Yes.
Now, after her treatment, she came back to Nairobi.
Kwani, she was still sick? I thought she had healed now in South Africa.
No, she didn't. She underwent a procedure in South
It was a
Africa.
procedure.
So she was not fully recovered.
I get.
And she still needed a medic to help with the transfer back to Nairobi. So I went down, came back with her, and when they got here, I thought that was it. Only for them to call me the following day. They were like, hey, Daktari, now our mom has said she doesn't want to go to hospital and she's requesting you come see her at home. So for me, I was like, no, surely I don't, what do you mean I see you at home? For me, I'm used to, if you're traveling, I'll come help you travel to whichever country you want to go and I come back.
Yes.
So now, but you know the way you want to keep some relationship. So
That's right.
So for me, I asked for a high figure, according to me. And the family was like, we'll discuss, but it should be okay. So they agreed to whatever amount I told them.
Yes.
And that was how I went and saw the mom the following day. But now she needed to be seen every day.
Yes.
Because she was still on oxygen at home. And they needed a doctor to review. The same way if you admitted, you see a doctor every day. So it was the same instance even for her. So I saw her the following day. Then they told their friends, hey, kuna daktari hapa anaona watu nyumbani. So it didn't.
They launched it for you.
So they told another friend.
Yes.
And you know the way you tell your friend, then they called me, they were like, hey, Daktari, can you come and see our mom? Oh, she's unwell at home. I was like, no, I was just doing them a favor, I don't do that. They were like, no, we even know how much you charge. So I told them, okay, I agreed. By the end of the first week, I'd seen 4 clients.
Wow.
So then that's when it hit me. I was like, wait, there's actually an actual need here.
Yes.
People need these services and nobody seems to be providing. And that's when it clicked that, wait a minute, this is something you can actually do. And now because of my traveling abroad, I had seen it. It was happening in other countries. So I knew it's something that can be done, but it was not locally available. And that's how we started. That was in 2018.
Yeah.
So we started the company, went, searched, and I found Daktari Msafiri was available. So actually I registered it as a company. And we started doing, and now we started the business. So initially it was a one-man business. And I would see the patients, go back home, invoice. If they needed any tests to be done, I would be the one to draw the samples from home, take them to a lab, then from the lab get the result. You know, like the whole, everything, every aspect of the business was the one doing it. But then I realized, so I actually got burnout. That was 2018, 2019, I got a burnout and I was like, I can't do this.
You are very busy.
I was very busy because now.
Just after those 4 referrals, they grew by themselves. You didn't.
So it was organic. People were just
put even an effort.
I was not advertising. People were just calling me. Oh, there's a doctor who can see you at home.
Yes.
And you see, that was 2018. So by 2019, people had known. Oh, now they were telling their friends, you don't have to go to hospital. This doctor will come to your house. They will do everything. They will get your test done. But I was getting very tired. So 2019, around August, I just got tired. I stopped working, got burnout. And for 2 months I was home doing nothing. Then September, school fees, ikanikumbusha, hey, you need to I need to be out. And that's when I went looking for a job. And at that time, a friend referred me to KU. They were looking for, remember my training is emergency medicine.
Yeah.
So they were looking for an emergency physician who could help them set up the emergency department.
Yeah.
So I removed my papers and I went to KU, and they hired me. We got started with KU. I was part of the team that actually started the hospital. The hospital started in October of 2019. So we started the hospital, and 2 months down the line, COVID came in.
Yeah.
So COVID came in towards the end of 2019, and when COVID came, the hospital was not yet ready for, no one was ready for COVID. So for me, one of the things about emergency medicine, on our training, it's preparedness. For you to respond to any emergency, the most important thing is how prepared you are.
Yes.
So we suggested to the CEO, we were like, look, we are seeing other countries getting this thing. That was January of 2020. We need to get ready. We need to prepare the hospital.
Yeah.
And now we are a new hospital. We had not even started admissions.
Yes.
So, and very soon, within a very short time, we had actually set up the whole we took up, I think, almost a whole floor and set up the beds, and we were ready for COVID.
Yeah.
So when we got the first client, COVID came in and we were ready. But now the interesting thing when COVID came, so my clients who had stopped seeing called me back.
Yes.
So they were like, hey, Daktari, no, now we are here in the hospitals. Can you see us at home? So yes. I would leave work and pass by their home, review, see how they are doing. But this time I was like, I can't do it alone. I have to get somebody. So I started recruiting other doctors.
Yeah.
And so they're the ones when I'm not, because some people would call me during the day and I can't go. Then I also got somebody to stay in the office, somebody now who was to receive the calls instead of all the calls coming to me.
That's right, yeah.
And then people are coming back from Europe. One of the requirements was if you needed to go for, you either going home or go for quarantine.
Yeah.
But the condition for going home is if you had a doctor who could take care of you at home, then they could allow you home.
Yes.
And for you to do that, you needed to fill in a form. So people called me and they were like, hey, Daktari, our friends are coming back. Are you able to make sure they can go home?
Yes.
This time I'm still working full time.
Okay.
So I asked them, what do I need? So no, you just need to fill in a form. And this is the form they will bring to KU, to the airport. So fortunately, I called a friend who was working. They were like, oh, yeah, we know about this thing. You have some people coming in. I sent him the form. And within a day or two, I had a response. And I emailed the person who was coming. One thing the person told me was, make sure you charge them.
Yeah.
So I charged them and I forgot about it. Only for me to realize people were taking such a long time to get those forms signed. So they told the word spread, there's a doctor in Kenya who can actually fill for you these documents and you get your... So within a very short time, so people were calling and on WhatsApp, sending me messages.
Yes.
And so at that time I thought about it, I was like, wait a minute, this Daktari Msafiri is waking up again.
Yeah.
And then the lady who had referred the first clients called me back and she was like, hey, in case we get clients who are positive, can you follow them up for us at home? I was like, yeah, sure, why not? So, but this time what I did is since I knew the problem I had previously of the issue of being overwhelmed.
Yes.
So I came up with a team. So I got a doctor. I knew there's a doctor in case I have clients who need to be followed up. They're the ones to follow up. I had a person at the office. So what happened is we set up. We got one. So what I did is I came up with a plan From what we were, the treatment we were given at KU, I came up with a package for this person. And I told them, this is the package, this is how much we costed it, and this is how much it will cost you to do the follow-up. And you remember that time insurance companies were not covering.
COVID, yes.
They're not covering COVID.
That's right.
So this person, they agreed. They were like, yeah, we'll, in case any of our clients turns positive, we're okay with the package. So we just discussed, yeah.
Just as you go on, I just wanted to inquire about that package. How is it? Because, you know, the other doctors also have, you almost have a kind of a standard package, a standard kind of fee.
Yeah. So this was very unique because it was for COVID.
Yes.
So the way we designed it, remember we are doing home care.
Home care, yes.
So for us, we designed it, we put in the medications that were required or whatever we were given in the hospital. So those are the medications I took, costed them and gave a price. And then also we'd get a nurse to follow. We were using telemedicine. So the nurse would follow you up for 14 days.
Yeah.
And then the doctor would call you at the beginning and at the end and any other time when you need a doctor to review.
Yeah.
So that's how we had designed it, and that's what we discussed with the insurance, and they were agreeable to it. And that's what they bought. The interesting thing is we would deliver the medication to your house.
Yes.
Because remember, this is COVID, people don't want to travel, you've turned positive, you're scared, and so interestingly, at that time we had a network of Boda guys all over the country.
Yeah.
So what we'll do is I would call my friend. If I have a client, let's say in Mombasa, I would call my friend or ask one of my colleagues to call and find out, you know, the way you say my Boda guy.
Yeah.
And everyone has this Boda guy they trust.
That's right.
So we got those guys all over the country. And those are the guys we were using. So we would send our items via bus, and when it gets to the other side, then the person would pick it and deliver to the client's home. And for us, that was our unique thing, because the client didn't have to leave their home during this COVID time. And so all the insurance companies came in and they put us in a panel, and we were doing COVID management for them. So any patient who turned positive under the insurance actually majority of the people we took care were the staff working with the insurance companies. And then before now, they started doing other companies. But that's how I realized that this business was still alive. You know, the way you say, now me, I'm back. In fact, the next step was now how I go back to flying. But
let me take you back a little bit. That time you went to KU, there is this business that peaked until you had burnt out, isn't it? So at that particular time you were looking for that job at KU. Why didn't you think about going back to your clients, or had you blocked your phone at that particular time? What happened?
No, I think I just, I got tired. Like I got tired of doing that.
Yes.
And in fact, when clients would still call. But I'll tell them, I stopped doing this. One of the challenges I had before COVID was convincing other doctors to join.
Oh, I hear you.
Because a doctor, you go and talk to a doctor and you tell them, I'm doing home care. It was very foreign. Like, how? Like, what do you mean you are seeing patients at home?
At home.
How? How are you doing it? What if you need this? What if you need the other? And that was most people would refuse. They'll be like, no, we can't do that. And then the other challenge with home care is if you go to a patient's home, you have to be very patient. No, it's the reverse. When they come to your clinic, they wait.
You are the one waiting.
When you go, you find, like I figured out, if you go to client's home before, like you can't go to a client's home at 8, especially the elderly. They're not awake. So I remember there's once somebody told me to go and see their mom at 8:30. But she wouldn't, she's asleep. And she doesn't want to wake up, and you can't force her.
That's right.
So mnakaa tu, mnagoja, wait for like an hour or two, just waiting until now she wakes up, and then now you go see her.
That's it.
So you see, most people will not agree to that. They'll be,
It'd be
you're
like,
wasting time
time.
and time. Yeah, and how much are you paying for that time? And so with time you learn like when to do the calls, you prepare, and yeah.
But you're billing the time also.
Yes. So by that time, so most doctors were refusing, and that's why for me it was like, if I'm going back, I can't do this alone. It's already overwhelming. So but now COVID came in, and the good thing with COVID is it opened people to the idea of home care.
Okay.
Because remember hospitals were full. I remember us guys by that time, we just before had, so one of the things we had gotten oxygen for patients at home.
Okay.
And during COVID is when now we realized, oh, people need actually oxygen at home, and they need a lot of it. So we supplied a lot of oxygen during COVID at home, because people are requiring the oxygen at home, and that became something now that people are happy about. You don't have to go to hospital, you don't have to be quarantined. We would go and wear those PPEs at people's homes.
But there's something that happened to you when you were at KU.
Yeah.
I can feel it. There is something that happened to you when you, as COVID was coming, that had more of a paradigm shift in terms of your thoughts. I don't know, in terms of coming back to this business of Dr. Msafiri. So that when you are coming back, even as you're giving the story, you did not come back the same person as the first instance.
No. Actually, yeah, I keep saying, for me, because see, the burnout is what I realized was the problem. And that's what made me not progress. And so when COVID came, I knew if I'm ever going back to that business, I will not be the one to do everything. And so when I came out, and even as I left KU, because eventually, actually home care became busy.
Yes.
I became busy, and at some point I was like, I need to leave one, and I left KU.
Yes.
When I left, one of the things I had to do was make sure I have somebody in the office. I'm not the one doing the administrative work. Somebody who can do that, another doctor to help, and also other people to come in. So basically you needed a team. Because I realized they can't do this thing alone.
It's not possible.
Yeah, it's not possible.
Yes. And that made now it a different business than how it began, isn't it?
So it was very different from when I began it. But I felt like, the way you feel like it's your destiny. You've tried to run away from it, but imekurudisha tu.
Imekutafuta.
Since I left KU, and the business now has been growing here.
Yes.
Yeah.
Interesting. So in this home-based care, is it specific types of diseases? But you mentioned you're dealing with elderlies.
Yeah.
But is it restricted to elderlies alone?
So what I realized is, if you look at the people who require home care, we realize majority of them are elderly. So you'll find I see a lot of, in fact, the average age of my clients is 75 years.
Okay.
So I have 90-year-old, 100-year-old, like people who are elderly. And what we realized for them is going to hospital is something they hate. In fact, anytime I get called, the children are calling and saying, hey, Daktari, our mom is unwell, na amekataa kwenda hospitali. That's always almost everyone says, they tell me that, like, is there something you can do? Come. In fact, some of them, I go, I see them, then we discuss, and I tell them, now, because you're very sick, could you go to hospital? The good thing with these old people is they respect doctors. So whatever the doctor says, they have to do. And some of them, we've actually ended up admitting them in hospital just because I went and saw them and they listened to me. So you find we get a lot of that. And also the elderly, they are at higher risk of infection. We call them hospital-acquired infections because the immunity tends to be low. So you find a person going into hospital with one condition, then they end up getting several other conditions. that they did not go with because the immunity is lower. So they also fear. There's a lot of fear among the elderly. So most of them will tell you, oh, you know, my friend went the other day to hospital and they didn't come out. So I also don't want to go. So if you're doing anything, do it here where I can see.
We can see.
Yeah, so then that's why we find ourselves getting a lot of elderly clients. And even for me, it made me now go back and start learning more about how to take care of them, how to better manage them. One thing we are realizing now as a country is as much as we know the population, majority of the people are young.
Yes.
There's also a high population of people who are, the retirees are every year, there's so many people who are retiring, and majority are still within Nairobi, still within the major towns, and that population is also growing.
That's right.
Yeah, so it's an area that is growing, as much as majority are still very young of Kenyans, but even the elderly are also growing. Yeah.
So basically, we're dealing with which type of doctors are you dealing with? Physicians?
So I tend to deal a lot with, so what we do is, as I say, the biggest challenge is, so when it comes to the doctors, so now we have more doctors now who are agreeable to seeing patients at home. The challenge is now the specialists. The specialists still don't want to go to patients' homes. And it's because of all those dynamics of time and traveling. But now what we've done is now we are bringing in a hybrid, where the doctor, who is a general physician, will go and see the patient and communicate with the consultant.
Okay.
So it becomes easier, and the consultant is able to transmit whatever information they need to the junior doctor, who is now able to implement the plan. And we are doing a lot of that. So you find patients who initially would go for maybe three to four visits to see a specialist. Nowadays they'll go maybe for one in the year.
Okay.
Yeah, so it reduces the traveling and also the other thing that now we are doing also is, so among, other than the elderly, we also see a lot of people with disabilities.
Yes.
Or people who are bedridden, either from an accident. We've also been seeing a rise in the number of some medical conditions, where, for example, a good example is ALS, where people just start to lose their function and they're not able to walk, they're not able to move, so they end up being bedridden. So such patients, we see them, because moving them from their home to hospital becomes almost impossible. And most of the time they require an ambulance to move. So you can imagine the cost and the time and the risk. You move a person from even let's say Kiambu to, they're coming for a clinic here in Nairobi. It takes them almost an hour or more to get that person from the house to the car. And most of the time they'll be using an ambulance. Then they go to hospital. Most of the time they'll queue for like 2 hours to see the specialist. Then they have to do tests, they have to do so many things. It ended up being a whole day affair. And now what people have realized is, if a doctor just comes home, they'll come, the person, they find them as they are.
Yes.
Even if the consultations takes about 30 minutes to 1 hour, it's at the comfort of their home.
At the comfort of their home.
Yeah, they don't need to leave. Yeah.
And these issues are more in Nairobi?
So what we are doing is, majority of the people we see are within Nairobi. But they're not, you find most of them travel to Nairobi.
Travel to Nairobi?
Yeah, because most of them will have come to Nairobi for care. Either they are coming, they are staying with their son, with their daughter.
Okay, I hear you.
And mostly it's because the same thing we were saying. You find a lot of services and a lot of specialists will be within Nairobi or the major towns. So that makes also most people come in to Nairobi for specialized care. And also sometimes you find back in the village, there are very few people to take care of this person. So it becomes easier for this person to come and live in Nairobi with a relative who is able to take care of them. get the medical care. So you see a lot of people who are living with their children or a relative, a close relative. But also what we are seeing also rising
Yes.
is also people who've lived in Nairobi all their lives and they have homes in Nairobi. We also seen them in their homes in Nairobi.
Okay.
Yeah, because people who are senior public servants, they retired a while back, and so we end up seeing a lot of them at home as well.
Okay.
Yeah.
So basically, this one is for. It looks like you charge a premium for this service.
So I wouldn't say it's a premium, and that's what I was saying. If you look at the cost,
The cost.
so if you imagine this person
Yeah.
was to get an ambulance. Getting an ambulance within Nairobi, the minimum cost will be around 6,000 to 8,000.
So it is a friendly cost at the end of the day, because
That's what I'm saying.
putting all these
So for
factors
us,
together,
actually, we look at convenience. The convenience is what we are giving you.
you are giving convenience, most definitely.
Yeah, we are giving you
Most definitely.
convenience, and I'll give you an example. There's one of the time we were called a client who was in Gatondo. The person who was their mom was living in Gatondo, and she needed to come for a review in a hospital in Nairobi. So what they would do is they would take so he would wake up 8, leave for Gatondo because they have an appointment maybe of 10.
Yes, yes.
So he lives in Lavington. So from Lavington to Gatondo, gets her mom,
Yes.
comes, stay in traffic. From Gatondo to Aga Khan, it will take them maybe another 1 hour, 2 hours before they get to Aga Khan, where they were going for their clinic.
Yeah.
Then it will take them another 2 hours to see the doctor, to do the test. By the time they leave, then because she has to travel,
Yeah.
somebody else also has to be with her, because now one of the daughters, in case she needs to be examined, the son will not be the one to. So by the end of the day, it will take almost 3 to 4 people for her to come to be seen in the clinic.
That's right.
So if you look at the cost, so this gentleman was a businessman. He was telling me of course he values the mom and the time, but the amount, it's cheaper and more convenient for him to have a doctor go all the way to Gatondo to take care of the mom,
Yes.
and come back than he himself doing it. Because then they would have to sit down, they have to eat. 3 or 4 other people are involved. So if you look at, in general, the cost,
Yes, yes.
it may look as though you're charging a lot consultation, but if you look at the actual cost of you just saying you won't pay that, you take a month, you'll end up spending more.
Yeah, that's right.
If you look at the issue of, we have clients who've been in ICU, for example. Recently we had a client who had ALS. ALS is where their body becomes weak, and we organized, and they were able to get to stay in the hospital for less than 2 weeks. And they were in ICU for less than 2 weeks. Then we went and set up, because you see, some of these conditions, you can predict the progression. So we were able to predict, and we went on working together with the neurologist, and we were like, can we push that we don't end up spending too much time in the ICU, for example?
Yes.
And we set up at home, and this person was happy at home. And if you look at the costs that we've saved the family, they spend 10 days in ICU. Most of the ICUs within Nairobi, the minimum you'll find in private hospitals, you'll find is about 200,000 per day.
Which is very high.
So, which is very high. So, and that's why you find most people ended up doing harambes and all that to cater for that cost. This 200,000 is able to take them for more than a week at home. That is an amount they would have spent every day in the hospital. So if you look at the savings that they are doing in terms of them being at home, and that's the only cost. You look at the convenience of this person being at home.
Yeah, so seeing your people around.
Seeing your people, seeing you in your house, knowing, and you see, people have this belief that if the doctor has allowed me to go home, I'm better. So,
That's right,
so
yeah.
mentally they get better. So even psychologically they know that I'm well. And actually we've seen more people recover better at home. I remember there's a client we took from also one of the private hospitals. The client had been there for some time in the ICU, and we assessed and we thought they were stable to go home, and we agreed with the physicians who were taking care of him. The wife to the patient, they were both from Germany. They didn't have any relative here in Kenya. What we did is when we took them home, and she had even stopped working because she had to take care of the husband. Every day she has to go to the hospital, make sure he's okay, spend time with him, make sure he gets all his medication, just be there. So she was not able to work. She would leave her house and spend the whole day in the hospital. The moment we took the husband home, the first few days were hectic because it's a new environment for her before we adjusted. But I can tell you after a week, this lady went back to work. She started doing, so she would go, she was a consultant.
Yes.
So she was able to go back to her consultancy work. She was able to, because in the morning, before she leaves, she'd see the husband, he's okay, he's the nurse. They understand, in case of anything, you can call me back. So she went, started exercising, and her quality of life improved by her husband being at home.
Yeah.
Yet he was still receiving the same care he was receiving in the hospital.
At the hospital.
Yeah.
And okay, I want to look at two things again.
Yeah.
How have you gone about to build the team to help you to do this? Where is it at now in terms of that construction, building that team? And
so two things. So
is it constrained to, because there are varied numbers of diseases?
Yeah.
But maybe are you choosing the most?
So for us, what we've done, and so we've set up a system where, so one, we are building a computer system at the moment, where it will help us to manage all this. Because one of the things we realized, like documentation, how we keep in our documents. So before we've been doing a lot of manual, but now we are slowly migrating to electronic health records. Because we've realized as the client numbers increase, it becomes almost impossible to manage. And if, for example, if I send one doctor today, and they send tomorrow another one, then they'll be lost. They won't have any medical records or previous history of that person. So we are trying to put everything in one platform where now we're able to do this.
Yes.
But also what has happened is a lot of training. So we've documented all the processes. We know what happens when you go, and this is from the challenges we had with people who were going before. People are able now to know, you go for a home visit, this is what is expected, this is what I'm supposed to do, this is what I need to carry. So we put in a lot of procedures and SOPs.
You're learning on the fly.
Yeah. So you don't have to think of what to carry or what to not carry. There's already a set plan that this is what you need. You carry this, it's already set. You go see the client. If they need this test, they're able to do. Because I'll tell you right now what we are doing is, so when you look at the team, so we have several doctors. We have 5 doctors who are able not to, in case we get a call within Nairobi, we're able to respond with a person on call every day.
Yes.
Then we have nurses, so people who need nursing care at home. So either we get a lot of calls, somebody needs an injection. Sometimes people go to hospital they are told you need this injection for 5 days. You can imagine this person is unwell, having to drive or take an Uber, or it becomes hectic. So many of these, we get a lot of injection requests. We get a lot of physiotherapy. You have physiotherapists now in our team. Yeah. We have 3 physiotherapists who are able now to take care of our clients. So in case they need physio at home, because physio is one of the elderly clients, most of them will require physio, or those who are bedridden.
Arthritis and such.
Yeah.
Arthritis.
but also, remember, if they're immobile, they are prone to a lot of pneumonias because of lying down for long. So they need a lot of physio. So we do that. We do a lot of physiotherapy at home. We now do labs from home. So
you are able to
the
kits?
Yeah, you do lab tests from home. We've even introduced X-rays. So you don't need to leave your house for an X-ray. So we come, do the X-ray, we do ultrasound, we do ECG.
Becoming a hospital.
So actually we are a mobile...
Msafiri hospital.
We actually are a mobile hospital. That's what I keep telling people, that we are bringing the hospital to your house.
To your house.
Yeah, so because we do everything, and you don't need to leave your house. If you need an X-ray, we do it from there. Now what we are working on now is the turnaround time, because you find most of the time you have one unit, so if it's doing an X-ray in another area before they move here, so that's what now we are working on improving on our turnaround time.
Turnaround time, yes.
Yeah, without compromising the care. So if you need nutritional services, a nutritionist is able to come to your house. So basically all the services you'd get in a hospital, you're now able to get them at home. The few areas we are not able to do, one is dialysis. It's something we've looked at, and we are hoping we can start that, doing dialysis at home. It's been done a lot in other countries. The only difference is the kind of dialysis we do in this country. We do a lot of what is called hemodialysis.
Yes.
Yet in other countries they do a lot of peritoneal dialysis. So you find, for example, in the US, a person on dialysis in the US, they set the machines for themselves.
They do what?
They set the machine. Somebody is at home, they have a dialysis machine. They know how to key in how much needs to go out, how much needs to come in. So you don't need to leave your house to go for dialysis.
Oh, I get it.
You just get dialysis in your house. And
it looks like a very green area.
So it's still
to be explored.
That's what I'm saying, like for us in Kenya and Africa in general, it's still an explode. I was talking to a friend yesterday actually, in Singapore.
Yes.
Singapore right now, and I know it's most hospitals abroad, one of the things they really focus on is when you're getting discharged. And they have targets. If, for example, this person comes in, they've come in for surgery, for example. If all they're staying in the hospital for is nursing care, they get discharged. Because if you come in for surgery, you're stable after 24 hours. They'll discharge you and you go recover at home.
So what is driving that?
Cost.
Oh, the cost element, yeah.
So if you look at costs of having somebody in hospital, it's usually very high.
Yeah, that's right.
A hospital bed is very expensive. As compared to this person, they have their bed at home, where they should be in their bed at home.
Yes, yes.
And even recovery is faster at home. Because there's no need for, actually most hospitals, they are more like, most hospitals become hotels. Yeah. Most of the service people receive in a hospital is a hotel, is hospitality services. So you're there, you're lying down, you're getting food. If you look at most people, they'll tell you I didn't even see the doctor here. I don't know if he even came. Yet you're in hospital, you'd expect, if you look at the contact time between a doctor and a patient in a hospital, trust me, is less than 15 minutes.
Yeah, sure, you're right.
The doctor will come, you're 10 of you in a room. Niambie juu ya huyu. The nurse will tell them, oh, this is where we are. We are doing this. Okay. He'll order one test. 5-10 minutes. And you'll find a lot of complaints. Oh, daktari alikuja hata hakuniguza.
Hata alikaa kidogo
dakika mbili. Yet, if you look at the bill you're getting in a hospital setting, you look at the cost of being there in that bed, the cost of the doctor visit, the nursing cost. So if you look at all those costs vis-a-vis what actually you're getting, or the care you're getting, that's something you can get from your house at a lower cost.
Yeah, you're right.
And that doesn't mean, and I think what happens is the challenge we have in the country is the quality home care services. Because you find also a lot, it's not regulated.
Yes, I wanted to ask about the legal framework of that thing.
So, and that's...
I heard the former First Lady had such kind of an arrangement. Daktari, I don't know whether it went ahead or not. There was some form of...
So you find what happens with home care.
Yeah.
So right now is when the board, the nursing council are starting to come up with the discussions. But I've been in those places, asked them, I'm doing home care. Their first question they ask, are you licensed? Yes. You go and do it. Like, are you as an individual, you have you're up to date with your licensing as a doctor?
Yes.
Then you can see a patient at home.
Yeah.
But if you realize how much is done at home, the problem is no one will come. It's very difficult and then you see people get nurses, even how they recruit. People will call a nurse, they know that so-and-so is a nurse, they'll call them, you come and give us care. Then can you get other people who can come and do the same thing you're doing? So you find it's it's not regulated, and that becomes a big risk for people. I've been to homes where you find people people think everyone working in a hospital is a doctor.
Yes.
As long as they have a white coat.
A lab coat.
That's a doctor. And you find the challenge with that is people tend to get the wrong care. Very poor care, and then what happens is they get the complications that they would have avoided.
Actually, when you think about it, even Derek, we might find that at your village, you might find this thing happening, but maybe at a lower scale, where somebody wants to be given injections.
Yeah.
And
the local pharmacies.
Local nurse, local clinic officer, and they're able to execute that.
Yeah.
You have to save the cost of going to hospital, the inconvenience, as you put it.
Yeah.
So you might, it is a need that is there, but of course at different levels.
Yeah. So I think for us, because of where we are, mostly we focus a lot on the private. But if you look at it from a public health perspective,
yes.
If you think about how many hospital beds, for example, ICU beds,
yes,
are currently available in the country, you find there are very few. Yet, majority, you find a patient spending months in a bed, in an ICU bed, and somebody who's been in a road traffic, a young person being in a road traffic accident, misses out on a bed. In fact, we've had incidents. I remember we even did, there's a movie which we helped produce called 18 Hours. Talks about a person who was in an ambulance for 18 hours. They've been involved in an accident. They couldn't find an ICU bed. All the ICU beds were full. Yet when you go to most of these ICU beds, you find somebody who's been there 2-3 months. And that time, that doesn't mean that the 3 months they've recovered. They're still there in that bed.
Or giving you even the temptation to choose who is going to live, who is going to...
If this person, for example, if you look at the cost, do you know, for you to have one ICU bed in a hospital, you need 5 nurses.
5 nurses?
5 critical care nurses. To make sure that every 24 hours there's a nurse on duty that is taking care of this person.
Yeah.
So if you think about that and the cost, and on average, an ICU nurse is getting paid maybe 150,000.
Yes.
So if you look at the cost of just having one person in ICU, the cost is very high. Yet, if that person who is stable was to be moved from that ICU bed, taken either, so you find in other countries what they do is they have what are called long-term care facilities. So where they know this person, there's nothing much we're doing for them. We're just maintaining the physiology for a certain period of time. We are not taking them to theater. We are not doing any procedure on them. This is a person who can be moved to a long-term care facility.
Yes, yes.
They don't need to occupy an ICU bed. So you find people are looking for ICU beds, yet if you had moved this person to a long-term care facility, they would still receive the care that they require,
Yes.
but they would free an ICU bed for somebody who urgently needs it.
Yeah, yeah.
So if you look at it from a broad perspective, you'll find there are a lot of the few ICU beds we have would actually benefit more people if we managed, if we moved most of these people. And it's very hectic to have a patient in ICU in a hospital. First of all, the visitors, they allow only 2 visitors, which is okay because they're trying to minimize infections. If this person is in their home, it's even easier for them to control the
Yeah.
people visiting.
Yes,
Because
yes.
if everyone hears, oh, so-and-so is at home, he's better.
Yeah,
So
yeah.
fewer people will come visiting,
Yes,
and they can regulate how
the
people are
hospital.
visiting.
Yeah, that's right.
But in the hospital, you have, and then cross infections. People stay there, you finish one infection, another person comes in with TB, you get it. You know, like
Yeah,
a lot of, so there's a lot of benefit, even from a public health perspective, if we were to allow majority of these people who are in ICU and who end up spending a lot of days in ICU unnecessarily.
Yes, and from a business perspective, not very many people, including doctors, can do what you are doing in terms of business specifically. So what kind of mindset would you have, or traits, for example, would you need for you to, because you have built this thing from somewhere until you just broke even and started the flying from day one?
No, I wouldn't say I think, okay, so several things have helped. One is I did accounting in high school,
Yeah.
and then I went ahead and did CPA. So that's part of the training I have. So and
After high school now?
after high school, before joining medical school.
Uh-huh.
So that has helped me to understand
So you
the
were-
issue of.
Sorry, you were thinking of doing accounting at some point?
I was actually, my options were, if I didn't get medical school, I would have gone to do accounting.
Okay, okay.
So that background helps me to understand when I'm given cash flows and know what a cash flow is in a business and what it means.
Yes.
So I know how to manage. I know it's the lifeline of a business.
So it is the blood
It's a blood, yes.
of the business,
It's
like
the blood of the
human body.
business. Yeah. So if you don't have cash flow, you don't have a business.
Yeah.
And this is something you're not taught in medical school.
Yes.
So that has helped. And then also joining groups and forums where people are discussing about business. So I'm in several of that, so of those forums. So you find these forums, like I've attended the Transformational Business Network. They have a 6-month program for business people. So they train you on how to manage a business. So you're trained on those things, on structure, managing your finances, marketing. So these are things, if you don't do them, if you just come in and say, oh, this is an opportunity.
Kuna biashara, I want to
Kuna
make money.
biashara, there is an idea, and that's why you find most people are able to transfer the idea into a business that would outlive them, for example, because they don't have that background. So and that's what I've been able. It's still a journey. I wouldn't say we've arrived where we want, but there is progress.
This mindset
Yeah.
that you need to run a business. This is a business. Of course, there is that advantage of accounting. What other thing do you think is very important in doing this that a new entrant, maybe from medical school or even from school just generally, would require to be able to get to a business, to operate a business?
I think one, you need to be a visionary. You need to, you can be able to see the opportunities. Because as we said, like, you're able to see opportunities and transfer or communicate those opportunities to your team and implement what you're seeing and make it work. Because you find, like, home care.
Yes.
I look at COVID. For us, COVID came in, I would say it came in at the right time. We were ready. As much as I was working, I had a form of a structure. It was very easy to regroup and start.
Yes.
And manage COVID and even come up with because we came up with that, we came up designing. So you have to be innovative. So you look at the opportunity, there's nothing in existence, so you have to innovate. So there needs to be a lot of innovation sometimes. I think the challenge most people the problem with us Kenyans is we are copycats. We want, mtu amefanya hii, let me go and copy them. Like during COVID, there were so many organizations that opened that were doing home care.
Yes.
And I remember when we were discussing with my team, guys were worried and they were like, hey, so many people have opened, are we going to still continue, will we survive?
Yeah.
And I remember for me, one of the things, and I think this is also what helps with the business, is you remain focused. Don't get distracted, because you realize most of the ideas also sometimes not very new.
Yes, there's nothing new under the sun.
Yes, there's nothing new under the sun. It's just the way you do it.
You do it,
But
yes.
are you also resilient? You have to be resilient also as a business person.
And also perfecting as you go by.
Yeah, you have continuous improvement. That's the other thing. One as an individual and also as a business. You have to keep, the times we've had to, so one of the things we realized, and if you look at how even our business has grown, is when I went and saw the patient the first day, and I realized, they needed the doctor to see them, but they also need tests to be done.
Yeah.
So I brought in the test. They need physiotherapy. I brought in a physiotherapy. So the business has grown that way. But then also you realize, I'll give an example. We recently opened a school.
Our school.
Yeah, and the reason we opened a school is because we realized the people we are going to see, they need to be taken care of at home. And the people we were getting in the market, we felt every time we get new people, we have to retrain them.
From hospital to home?
No, the ones who are already in the market, the caregivers.
Oh, the caregivers, okay.
So you get them, then before they go to a home, you have to train them. So we found it easier for us to just train our own. Yeah. Then they have our culture, and it becomes easier for us to send them to clients' homes. And that's what we've been doing. Actually, started training our own caregivers. So it's us looking at opportunities that are emerging from what we are doing and seeing how we can tap into those. So I think as a business person, you have to have your eyes open. So we're always looking out, what are the trends, what are people talking about, and for us, as much as we are, so what we've done is we keep our core business still as our core business, but in case we get other opportunities, we still see how we can handle them so Daktari does a lot of things. Another thing we do is, for example, we do corporate wellness, for example.
Yes.
And it's something we've seen is a trend that is coming up. Corporates we've seen a lot of organizations, instead of getting to pay premiums for the employees, they're opening a fund where they manage the money, and they either pay out to a hospital depending on the cost, and you find most people are saying they're saving on the amount of premiums they had to pay. You find an organization that was paying like 100 million, for example, Kenya shillings. Just by having a fund, they can end up spending even half of that money or less.
Oh, okay.
And what they're doing. So we realized that's an opportunity, and that's how we ended up with one of our organizations like BATA. BATA we service BATA as a medical provider. So that's not home care, but you see, it's also an opportunity that came in. And now we are doing wellness for corporates. So
That is more training
so we do for them their medical checkups.
or checkups.
So every year, every person gets they told you are entitled to a certain amount of, you can go for wellness, you can go check your cholesterol, your lipid profile. And when we realized that was an opportunity, we still went for it.
Okay, so basically.
So, but what I'm saying as a business, if you stay narrow-minded and you're not seeing these are the low-hanging fruits, so you have to grab them as you're still going on
in a focused
in
direction.
your focused area.
Okay.
Yeah, so and that's what we've been able to do. So I think as a business leader, that's one thing you need to focus on. You need to know, this is my core business. This is what I do. You become the best at it. But if you find low-hanging fruits, you grab on the way. Yeah.
This years you just made money from day one going, or you how did it go with the
No, I wouldn't say it's been a challenge, and I would say one of the things, having the accounting background, one of the things I knew I had to take care of is the cost.
Yes.
So you'll find I tried to keep the cost at the bare minimum, and that's why maybe initially I didn't have any employee.
Yes.
Because I was like, what will this employee come to do?
Yeah,
if they're coming to do billing and keeping records, I can do that for myself. I know how to do it.
Yes.
So I was the only employee in the company. But then now we realize is how do you have to keep them in. So, like for example, we stayed for a very long time without an office. And the reason was I was operating from the car. And the people who were working with us, like the accountant, they were offline. So we'd do meetings online and discuss. So that helped to save costs. So you find even our break-even point becomes lower just because we don't have a physical office. I would say it took us, but when we started introducing now more people, then also how we bill, for example. We've been doing a lot of consultancy. So you find if it's the physiotherapist, because this is on a need basis. So you find instead of hiring them permanent, it's more of as a what you call locum. So you only pay them when they provide a service. And so that has helped to keep our costs low and to make sure that we're always meeting our costs. The challenge we have is you'll send a nurse, for example, to a client's home. You've agreed on that locum rate and they've stayed, for example, a month. Then at the end of the month, you have to pay them. So the challenge we face is families failing to pay. So collection.
Collection.
So collection becomes a problem, and that is what now affects our business. So you find the model is working, but if clients are not paying on time, then that means you end up making losses because you've not received from the client and you still have to pay your nurses.
How do you mitigate that? Is it possible to mitigate it?
So one of the things because it's become a challenge, so we now reduce the billing time.
Yes.
So before we used to bill every month.
Weekly or something.
So now we do weekly. And we also do a deposit. Like before, if we are taking you for a long time, you need to pay a deposit. Then we'll be deducting from that deposit. And if it's more than a week, then we are very cautious. If you're going for more than 2 weeks, then we know this is a red flag.
Hii kitu umesoma hasa on the go, sindio?
Yeah, this is hands-on. But you see, it's what we are saying, continuous improvement. So you keep learning and then you keep, also how we, I wouldn't say we refuse clients, but also we look at clients. So there are times we've had clients, for example, in the past, who are from another organization.
Yes.
Then they request us to take over from the other organization. Before, we would maybe just get the medical history about the person. And we think it's a favorite, it's a good client you're getting. Only for us to realize the reason why this organization is leaving is because they're not being paid.
Yes, yes.
So also doing some background and that has also helped because the challenge with home care is sio kama hospital. You know, in a hospital, if a person doesn't pay, You can tell them they will not leave the hospital until they pay.
Yes.
In home care ako kwake. Na anaweza kosa hata kukufungulia.
Hawezi sema utabeba TV. Utaenda na TV.
Utaenda na TV ya client. So huwezi sema ati utakuja, you take away their things.
Yeah.
So remember there's once a client aliniambia enda na hiyo pickup. So I was like, I can't take your pickup. I can't do it, take your pickup. I just need you to pay me. So kwambia wengine akwambia you know, those are actual challenges that people have. So it's still, and that's why I think most people fear going into that line, because then your money is not guaranteed at some time.
Yeah.
But the good thing is with the weekly billing, it also becomes easier for the families.
Yeah.
And also because we realize it's also communicating with them, making sure they know this is where we are in the bill, what's the plan.
Yeah.
One of the other good things is now insurance companies have started coming in and they're taking up and paying for their home care. So because also insurance have realized that if they save cost, they've realized, I'll give you an example. A child who gets even something like tonsillitis, for example, it's a condition, and sometimes they are required, because they're not able to swallow, then they need to have treatment through the vein, IV medication.
Yeah.
So if you look at that child, yes, they are unwell, they have fevers, they're not able to swallow. But the child is walking, and you know, this child that is at no risk. The risk of getting severe is there, but it's also very low. This is a child ideally who can be managed from home. So you end up with a child getting admitted for IV medication. Yet, if this child, they're only getting for that's something they can get from home.
Yeah. That's right.
So, and that's where, so insurance have also realized that they're spending a lot of money in paying for hospital bills, where
The home-based care makes it much more cheaper.
it's cheaper. Yeah.
And from your perspective, this business of hospital,
Yeah.
anasema somebody was telling me, ukifanya kazi kwa butchery, huwezi kuwa unaogopa damu ikumwagikie kwa koti. So there is this loss of patience.
Yeah.
I think it's something that happens, and this looks like more, you have a little bit more attachment than in the hospital. I don't know.
So actually home care, you become more attached.
Yes.
Because remember, this is personalized care. So you'll find, because you also become very close with the patient and their family members. And like some of the clients we see, the family tells you have to see them every week.
Yes.
Whether they are sick or not.
Yeah.
You just go and see them. And because this is somebody who is elderly, they just want to make sure their grandfather is well.
Yes, yes.
You go enda tu, hata kama utapima tu pressure. So what you end up going, mnachapa story. You start talking, you spend like an hour. Fine, you do an exam, but most of what you've done is more of the social.
The social.
So you bond with these people. They tell you their stories, and you start to get to know each other more. And because their condition is stable, if they have diabetes, if their sugar is 6, whether you go to, it will remain the same, and they are compliant on medication. So you get to know. So the moment you lose such a client, then there's, because you find we attend most of the funerals of our clients. Either myself or one of us will attend. And it's because you've come to know the family, they know you, because this is personalized care.
That's right.
So you get to know them, and I think that's also part of what has been pushing the business, is people are looking for that. People are moving from, I'll give you an example. A lot of the clients we see, they have relatives abroad. So if a person is in the US, for example, they want their mom who is here to be seen, they'll say they're willing to pay any cost at any private hospital. So the person is taken to a private hospital. Then the person on the other side requests to talk to the doctor. The doctor will not agree to talk to them. So you find a lot of frustrated people who are abroad. They are relying on second-hand information from a relative who is here, maybe doesn't understand much. So they end up losing a lot of. So what is happening is the moment they realize, oh, there's a doctor we can talk to directly. So we become their spokesperson here. And we direct care. You find, I'll tell them, okay, so for this condition, let's go to this hospital. For this, let's go here. For this, let's do this test. And that's what we do as a business. As I said, we do convenience. For me, I say I'm not in the business of health. I sell convenience. That's my product.
Yeah, that's right. Yeah.
So I'll tell you, you need a cardiologist. Go and see this cardiologist.
Yeah.
When you see the cardiologist gives me back the plan. He's like, oh, this person needs 1, 2, 3, 4. Then, because now me, I have the time. I'm able to come down and sit down. This is what you went. So the cardiologist, this is what they think you have. This is the plan. And you're getting this medication because of 1, 2, 3, 4. And then I continue seeing you at home. Okay. You're supposed to go back after 3 months. So you find, because of that convenience and personalized care.
Yeah.
And for me now, that's where the advantage of having some business background. I know that's our unique value proposition.
That's right. Yeah.
And that's what we focus on.
Yeah.
Convenience, making sure it's personalized care, it's efficient, quality. So when we start doing those as our unique value proposition, then we get more and more clients coming our way.
Yeah, that's right. Then I wanted to touch a little bit, maybe as I'm winding up, on the advice of living healthy. How would somebody, not elderly, or even elderly by the way, would they choose to have a lifestyle that is healthy? Because I think everybody wants to have some more mileage here on earth.
So actually the reason why we went into wellness as an organization is because what you've seen. These people we are taking care of in their old age, they have diabetes, hypertension, they have a lot of chronic illness. When you look back, it's a lifestyle. So and wellness is actually, it's not a pinpoint thing. It's a lifestyle you choose. And even when we do wellness, even for corporates, that's what we are looking at. We are not telling them we'll come one day, take your blood samples. No. Yeah. We walk a journey. We walk a journey together, and wellness is a journey. That's what I would say. Because it's the small things that you do every day that determine how healthy you are.
How will you be at 60, 70?
Yeah?
How healthy you will be at 60, 70s.
So the choice of waking up maybe half an hour earlier to go for that jog, to walk, the choice of food, you go, most people will go to a buffet. How do you serve? What do you serve? You be there.
Everything.
Ama sahani ni yenye. And one of the problems we have is most people came up from a poor background, and anytime unakuwa exposed, for example,
these are rare occasions.
These are rare occasions. So unaweka kila kitu, so you find choice, and it's all about choices. So are you choosing to kuna ndoma, kuna chapati? What do you choose?
Chapati.
So you see, that's how. So small things that people keep choosing, and that's how their lives they get these lifestyle diseases. The choice of soda, water. People will choose soda, and you see, it becomes every day. Every day you're choosing these things in small bits. They now end up destroying you.
What is the problem with soda?
It's the sugar. The high sugar content.
High sugar.
Yes. So you're taking very highly refined. We're talking about refined foods. The choice of taking unga ya ugali ile iko kwa duka versus zile ya kusiaga. So in fact somebody was making fun. Unapea ng'ombe the good part unakula hiyo ndani which should be the one you're giving the cow and you taking the other one. The other one. So you find and it's all choices. So the small choices that we make every day are all determine how healthy we become. So it's not the big thing that we do, but it's wellness is an everyday choice. And then the other thing is, of course, doing the checkups. You find most people don't do the checkup, and that's why we end up with people coming in when they are very sick. Yet, if they had actually done an annual medical checkups, most of these things would have been picked up: the high blood sugar, the blood pressure. Squeeze kupimwa pressure. I think in most chemists it's actually free.
Iko baka kwa pharmacy.
Yes. Pharmacy anywhere in your home, it's free. Enda upimwe, uambiwe, and you find a lot of people collapsing. And unfortunately now it's even happening in younger people. Nasikia mtu alikuwa sawa, na collapse. If they do a postmortem, you'll find they had high blood pressure, which was unrecognized, but they just collapse. So doing those wellness checks, and for me what I say is the wellness check doesn't have to be the 20,000-30,000.
Yeah.
So the problem is if you're doing it just once, and that's where we are discouraging. Don't just do it once. You can spread it out, and it comes. So you can say, let's say this month I'll just check my blood pressure and my blood sugar. The most utalipa ni 100 bob.
Yeah.
And trust me, those two tests you've done will give you a lot of information.
Yes.
The next time you can do a full blood count, a urinalysis with less than 5,000. You're umefanya almost everything. So it doesn't have to be, and then also depends with your age. So kuna a certain age, you need to do a prostate, you need to check your, for women they need to do a mammogram after 40.
Yes.
So you can do a mammogram today, another 2 months, ujipange, ufanye, you don't have to do, watu watasikianga wellness, 20,000 inakaa mingi. But if you break it down, it becomes manageable and easier to do it.
Yeah. Okay.
So, but I think for it to remain, it's an everyday choice. You need to make it every day. Then something else that I've seen that helps a lot is also being in a group. So if in a group that is keeping healthy, people, we call it a buddy system. Unajua kuna ule best yako mnaambiana.
Yes.
You're going to be healthy, we are going to keep fit.
Yes.
You're going to watch what you're eating. So have somebody who is keeping you accountable. Mwenye anajua, tutaenda hizo medical exam pamoja. Tutaenda, can you exercise tunaamshana? We check on each other.
Yes.
So we're able to do all those things. The other good thing nowadays, technology has also come in to help. So there are those fitness watches that people can get, and you don't have to get a very expensive one. There are cheap ones which actually just monitor your steps. And you're able to know how many steps you're doing, at least 10,000 in a day. So if you're able to get those simple and cost-effective things, you'll remain healthy.
Yeah, that's right.
And choose to walk instead of driving. Choose to take the stairs instead of the lift. And so the choice is every day.
Kwani exercise is very heavy on health.
So exercise, actually diet is more. 2/3 of fitness is mostly from diet.
Or diet.
Diet, what you're eating is what determines how healthy you are.
Okay.
More than the exercise. The exercise is about 1/3. That's why you see even for people trying to lose weight, the focus more is on diet.
Then it should be more on the diet.
It's the diet, then the exercise. The good thing with exercise, it helps a lot with the heart. So you need to exercise. We were created to walk, but nowadays the current man sits and then boda zisaidi So unabebwa hivi na mat, unabebwa na mat, unashuka, unachukua boda. People kitambo walikuwa wanatembea most of those distances, and most of the illnesses that they were getting they could not get them. But now because of boda, then wakule whatever they're eating, people nowadays rarely cook at home.
KFC.
Siku hizi watu wanakula out. You drive through. You don't need to. Yeah. So it's a small everyday choices that you make that determine how healthy you become.
Yeah. Sure.
Yeah.
Derek, you have something else?
Yeah, so kabla mtu akue, before you become a doctor, so of course there is a passing of exams. Right now I think the minimum grade ni A- to get and mostly it's the positions that are available. Even in other hospitals, they'll put C+ as a requirement, but trust me, the people who get picked, because there's so many people with A's, A-. They never get to the B's and the C's. So they'll still pick the A students.
Yes.
How do you utapata? But anyone with a C+ is allowed to do. That's the requirement. Even for Nairobi University, it's a C+. But of course, it's so they end up picking the top students.
Yeah.
So you'll do. It has changed. During our time, we do 5 years. It used to be marathon. 5 years. We do 1 year would be 44 weeks. So we do 22 weeks. Then 2 weeks break, then another 22 weeks.
Yes.
So now it has changed. Now they are doing almost 7 years. So it's longer. So 7 years of training, undergraduate. Then you do 1 year in internship. So that's 8. Then now after internship, you can now go back for your master's. Usually we recommend at least 1 or 2 years after internship to get at least ndio ujue where exactly you want to end up. So it will take you about 10 years to go for your master's. Most masters you'll do between 3, depending on which one you're doing. If it's something like pediatrics, it's 3 years. All the surgical programs are 5 years. So if you see a surgeon, they've taken at least 15 years to become a surgeon. 15 years post high school training to become a surgeon. And then now, of course, now there are subspecialties. So you find a person is a surgeon, but then now they've decided to subspecialize. Then now that takes another like 2 years.
Yes.
So if you get a cardiothoracic, those ones have cardiothoracic is actually longer. Neurosurgery, those ones they tend to take longer than the other programs. So on average, by the time a person is a consultant, they've taken about 15 years post high school training.
Shika hiyo.
Miaka mingi sana.
So asante sana daktari for having this conversation with us. Shall share this knowledge with these viewers of ours. And as we ask them to subscribe to this channel. Otherwise, thank you very much for giving us your time.
Karibu.